Hello, my name is Dr. Roger Henderson, and I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me on there too, at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings, which occur throughout the year. Now, in this episode, I'm going to be discussing acute appendicitis, which is one of the most common causes of an acute abdomen in the Western world, and in about 90% of cases, the infection develops as a result of obstruction of the appendix. So, for example, by a fecalith or an engorged lymphoid system, for example, due to a viral infection. Now, as we know, it's the most common surgical emergency of childhood, with 3 to 4 children per 1,000 having their appendix removed every year. And it can occur at any age, but in children it's most often seen over the age of 5. Overall, about 10% of the population will develop acute appendicitis at some time, and it occurs most commonly between the ages of 10 and 20, but can occur at any time during life, and it seems to be slightly more common in men than women. Now, the classical clinical feature of acute appendicitis is obviously abdominal pain. But there is a pattern to this usually. It tends to begin as a vague central discomfort, which many patients put down to indigestion and ignore. If the cause is obstructive, it can be a little bit more colicky. But either way, after a variable period, usually a few hours or so, but can be up to 2 to 3 days, the pain then slowly shifts to the right iliac fossa, becoming more intense and continuous. Now, that central pain is referred and thought to be due to stretching of the appendiceal wall. So the important thing about the early pain is its central location rather than its precise level. The later right iliac fossa pain is thought to be due to the first involvement of the parietal peritoneum, somatic pain as opposed to earlier visceral pain. Now, along with the pain, we have associated symptoms and signs. Classically, nausea, vomiting, and anorexia. Rapidly progressive cases may have recurrent vomiting without fever or diarrhea, and initially, temperature and pulse are usually normal. What can then happen is a low-grade pyrexia develops, and if the pulse rate starts to rise, that can be an indication of peritonitis developing. We then get the localized tenderness, guarding, and the typical rebound tenderness we look for in the right iliac fossa, and Rovsing's sign may be positive. It's one of those signs we learn as medical students, but just as a reminder, palpation of the left lower quadrant of the abdomen increases the pain felt in the right lower quadrant. Right iliac fossa peritonism can also be demonstrated by percussion tenderness or rebound tenderness. I suppose it's also worth remembering at this point McBurney's point. So this is defined as a third of the way along a line from the anterior superior iliac spine to the umbilicus, and its importance lies in the fact that tenderness and rebound at this point is often highly suggestive of appendicitis. We should also remember that elderly patients with appendicitis may present with confusion but no pain, and they may also present with shock, and in very elderly patients, progression can be very rapid. Now, some doctors do like to score appendicitis as part of the diagnostic process, and I think this is absolutely fair. And although the diagnosis can be made on clinical history and examination alone, in some cases, sometimes in early appendicitis, this can be more challenging. And we do know that scoring systems have been shown to be useful in determining the need for further investigation and treatment for acute appendicitis. Now, a number of these are available. The one I tend to use, if I'm using one, is the Appendicitis Inflammatory Response Score, or AIR score. And this scores a number of indicators. Vomiting, which scores 1. Right iliac fossa pain, also scores 1. Rebound tenderness, which scores 1 if it's light, 2 if it's medium, and 3 if it's strong. A temperature greater than 38.5 degrees, that scores 1. And the percentage of polymorphonuclear leukocytes in the white cell count scores 1 from 70 to 84% and 2 for over 85%. A general white cell count scores 1 of 10 to 14.9 and 2 for over 15. And finally, a C-reactive protein level of 10 to 49 scores 1 and over 50 scores 2. Now, if we then add all those up, a score of 0 to 4 usually makes appendicitis very unlikely. A score of 5 to 8 should trigger observation with serial re-examination, imaging, or diagnostic laparoscopy depending on local practice, and a score of 9 and above should trigger surgical exploration. So as I say, whilst appendicitis is traditionally thought of as a clinical diagnosis, we do know that clinical assessment alone can be unreliable, especially in groups like older adults, infants, and even pregnant women. So investigations to consider here include urinalysis to exclude a urinary tract infection, a pregnancy test to exclude ectopic pregnancy, and I would say this is absolutely essential in women with any possibility of pregnancy in whom you are considering the diagnosis of acute appendicitis. Full blood count, which is usually showing a mild leukocytosis, but do remember, a normal white cell count does not exclude appendicitis. And again, although the CRP may be raised, a normal level does not exclude a diagnosis of appendicitis. Imaging, in addition to these, is a useful diagnostic tool, and I think is probably most useful in patients where the diagnosis is indeterminate. And perhaps the most common one we would go to first is ultrasound. Tends to be preferred in children and young people and pregnant patients, largely because of the radiation risk that can be associated with the CT scan. However, if you have a very obese patient and you're looking to diagnose appendicitis, it can be difficult to obtain good diagnostic images in patients with suspected acute appendicitis and a high BMI. So CT scanning is more sensitive and specific than ultrasound when diagnosing acute appendicitis, and MRI is usually reserved for use in pregnant women as a second-line investigation after a non-diagnostic ultrasound. Now, when we're looking to treat appendicitis, the bottom line here is that all suspected cases should be admitted to hospital. Surgical appendicectomy remains the best treatment, the gold standard treatment for acute appendicitis in patients fit enough for surgery. Now, although antibiotic treatment can be effective in patients with uncomplicated appendicitis, some will still require surgery, and this may be more extensive if antibiotics have failed and surgery is delayed, and there's also a subsequent risk of recurrence. In these cases, it's also possible to categorize acute appendicitis as complicated or uncomplicated. So an abscess or perforation are consequences of complicated appendicitis. but antibiotic regimes in acute uncomplicated appendicitis usually have the most popular combination as cephalosporin with nitroimidazole, followed by quinolones and penicillin with a beta-lactamase inhibitor. However, an important point here is that up to a third of patients treated with first-line antibiotics will still require surgery, and there's a substantial risk of recurrence, and delaying surgery increases the risks of more extensive intervention, with obviously the associated costs for both the patient and the health system. Now, the error rate in diagnosing patients with pain in the right iliac fossa approaches 40%, and the appendix is normal in around 20% of patients who have it removed. So the three signs and symptoms that I would ask you to remember that are most predictive of acute appendicitis are: 1. Pain in the right lower quadrant, 2. Abdominal rigidity, and 3. Migration of pain from the periumbilical region to the right lower quadrant. A delay in the diagnosis of appendicitis is therefore more likely to occur in patients who present atypically, with fewer complaints of right lower quadrant pain and the absence of any nausea or vomiting. Also, the delay in diagnosis is more likely to occur in patients who do not have a thorough physical examination, and I would include a rectal examination in that, and also in those patients who receive intramuscular narcotic analgesia for undiagnosed abdominal pain or symptoms, as this simply masks them. We mustn't forget that diagnostic delay can also occur in patients given a diagnosis of gastroenteritis despite the absence of typical diagnostic criteria such as nausea, vomiting and diarrhea. And finally, diagnosis is often delayed in those patients who are not asked to re-present for review within 12 to 24 hours. So, it seems obvious to say that careful attention to the patient's history, a thorough physical examination, an early clinical review with re-review, if necessary, will minimise the possibility of a delay in the diagnosis of appendicitis. So I do hope you found that brief run-through of acute appendicitis helpful the next time you're seeing a patient and you're considering that diagnosis. Do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. We really do love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups that occur throughout the year and to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.